Hello and welcome to Sensei podcast. This is Manos Brilakis discussing with leaders in the field of CTO and complex PCI. Sensei means teacher or master in Japanese. The goal of the Sensei podcast is to help you learn and improve in CTO and complex PCI so that you can become the best that you can be and offer your patients the best possible results. Hello, everyone, and welcome to Sensei Podcast. It is my great pleasure to introduce our guest today, Dr. Javier Escaned, who is the head of interventional cardiology at the Hospital Clínico San Carlos and professor at the Complutense University in Madrid. He's one of the premier CTO complex operators, a master of coronary physiology. He has led several clinical trials and a great friend. And Javier, thank you so much again for being with us today.
Thank you for having me, Manos. A great pleasure to be here.
So Javier, this is about learning your course and how you learn to do complex PCI and the research that you are doing. I know you trained in multiple places. So walk us back in time. How did this all come for you?
Yeah, so I was very lucky when I started my training in the UK. I had done some training in Spain before moving to the UK, 1987 roughly. And I was very lucky that the place where I landed was the Queen Elizabeth Hospital in Birmingham, where one of the pioneers in introducing PCI in the UK was working, Manfai Shiu, an outstanding mentor and master. So definitely that, or in a way, they took me to the field of interventional cardiology from the very start of my training as a cardiologist. And I worked with him, I was in the UK for around 5 years. So it was absolutely great to have a mentor like him. So that's interestingly, my first communication to the scientific meeting, it was the ESC in Stockholm, probably was 1989, I believe, was about CTOs, because Manfai was a very skilled operator. And he was doing lots of work on CTOs at the time of balloon angioplasty with the gear that was available at that time. You can imagine that. And I remember that my first communication as a poster, actually, to a congress was on CTOs. So that's something that probably left, a landmark from the very beginning.
Wonderful. And then, but those times obviously was very early. Techniques were very rudimentary. Equipment was not there yet. How did things evolve after that?
Well, they evolved drastically. I mean, just to give you an impression, this would be interesting for the colleagues. At that time, when we were performing PCI in the cath lab, when we ended the procedure, we left the balloons and the wires, etc., in a tray with a sterile saline, covered with a drape. And we will keep them overnight because the chances of having to come back in the middle of the night to address a blood vessel closure were very high. So you can imagine how things were. And I think that actually, we can speak later about that, but there was a dramatic point in the history of interventional cardiology when that changed, which was the introduction of the coronary stents. So before the introduction of the coronary stents, the operator had a very strong feeling that the quality of the PCI was linked to the results, to the outcome of the patient, because actually it was the in-hospital outcome of the patient. And from the time that we had the stents, after the period of adaptation to use stents, 99% of our patients leave the hospital alive and without a problem. Irrespective of the quality of the intervention you have performed. So I think that is something that we can discuss later, but certainly it was a time where you really should be learning from someone who was very skillful, and you will know that he was very skillful because the patients will be, in most of the cases, doing well. That was the rule.
Wonderful. And then, things evolve over time, and I think you went to the Netherlands as well. So how did that come, and how did that help you in the things you did later on?
Well, again, that, speaks of a great mentor. Manfai knew, that they were very keen on the work that was performed at the Thorax Center. At that time, it was, I think that there is little doubt, the leading center in interventional cardiology in Europe. And he wrote a letter without telling me anything. He wrote a letter to Patrick Serrais. He knew him. He was a good friend of him, saying, I have a fellow who is very keen on your work. I think that he will be in the future probably willing to be with you. So suddenly I received a letter from the Thorax Center, with the conditions to become fellow. Out of nowhere, out of the blue. So, and it was amazing. It was amazing. And then later, the secretary handed me a copy of the letter that Manfai sent to Patrick Sorais that I still keep with me. Of course, it's a very important document, which was fantastic. So it was the first lesson of the importance of having a good mentor.
And you've done the same, obviously, for many fellows down the line, which we'll come to in a minute. When it comes to CTOs, when do you go back to Spain, and when do you start doing CTOs in Spain?
So after becoming, after say achieving the degree of competence as a cardiologist, so I was certified in the UK with the certification that was issued at that time. I did my PhD in the Netherlands. I was working as a clinical fellow, so I was involved in the cath lab. I had the opportunity also to liaise with patients in my Dutch, that by now is nearly gone, but it was a great experience at the time. And then I came back to Spain, and after a short working La Coruña and in Barcelona as well, I came to work with Carlos Macaya, who was one of my mentors again, a leading international cardiologist. And that was when I truly started to work in the areas of CTOs. Now, it was the time, Manos, that the instruments we had were things like the Magna wire, for example, which was a big 0.021 inch wire with a big olive at the end, which was also handled with a sort of catheter called the Magna rail, which was providing additional support. The idea was that something that would be very blunt, will go through the occlusion. Then I remember very well when the first hydrophilic wires came out, the Terumo guide wires, which was a big revolution. So that was part of the whole story. And I tried many different devices. I liaised with many different colleagues, we also even did some work with the Prima laser, the Prima wire. That was very thin one. But obviously, the big change came when I met the Japanese operators, and I started working with them regularly. And that was around 2007, and that was really the big change in my orientation regarding the performance of CTOs. And I've been, certainly following that particular line of work since then.
Wonderful. So a lot of influences, as you know, from the UK, from the Netherlands, then with Japan. So a lot of influences are making your own style of PCI. Now, I know as you said, you've done so much work in research, and you've been a leader in research for many years. How did the CTO work and the complex PCI work blend well with the physiology and imaging work that you have done and you are still be doing?
Well, I mean, certainly I was very curious from the very beginning with CTOs regarding collateral development. I remember that was, even when I was in the UK, I already was reading a lot of Wolfgang Schapper and, the pioneer work of Tennant and Biggers in the 30s about the collateral development. Then I remember lots of work coming from the States from Cohen. I was very interested in this particular aspect. And also, remember that at that particular point, we were very interested in the open artery theory, the idea that, it would be important to keep the artery open after myocardial infarction, but also, of course, the situations that you will have a hypernating myocardium in a chronic coronary syndrome, etc. So I always kept in mind, that it was important to open occluded vessels, and the rationale for that is that along your clinical practice, you will see in many occasions this devastating situation of a young guy coming in cardiogenic shock, first presentation. And what happened is that this patient had, an occluded LAD and now chronically occluded LAD, and now suddenly there is an acute event in the collateral donor artery, that is the right coronary artery. So everything, goes absolutely crazy. So I think that was a sort of inspiration for me. In around 2008, I believe, I joined the EuroCTO club. It was, formed by the colleagues, and I tell you that at that time I had already organized the first meeting that we had in Spain on CTOs, and I can tell you that it is according to the colleagues that were there, like Klaus Reifert and many other colleagues that were around. It was unique because we chose for the date of the Congress a solar eclipse. So there was a complete solar occlusion. So, and I remember very well, that what we did is that during one of the live case transmissions, we were time to time interpolating some pictures coming from the astronomical observatory, where you could see that the sun was becoming. And then at the point, that was nearly there, we opened the doors and we handled eclipse goggles to everyone, so everyone could go out to see eclipse, and we took champagne, and it was a big, big thing. So it was a really unique opportunity. So Gerald Werner and Klaus Reifert, and they keep saying me there was never a meeting on CTOs like that. That was a unique opportunity. So yeah, so that's in a nutshell and in a formal way some of the hints on my interest on physiology and CTO.
And then, obviously, as you say, I don't think there's ever been another meeting with a solar eclipse and CTO, so that's probably very hard to beat, given the timing and everything, the rarity of this event.
Yeah.
But when it comes to, you've taught so many, you're teaching and you have taught so many fellows and residents in doing PCI and physiology and imaging and all the studies. What do you find is the most difficult thing to teach the new generation? Are there specific hand skills? Is it the mindset? Is it some other knowledge? What do you think is the most difficult way to impart knowledge to people?
Well, there are two ways about it. On one hand, the challenges that the specific difficulties, may be more related to the characteristics of the person, and in general, what I insist a lot is in the importance of proper planning, and that and anticipation. And you wrote a fantastic article, and I'm very fond of philosophy. We can speak about later about that, but you wrote this fantastic article about the importance of from the stoicism, of be ready to be in the worst possible situation, And I think that is probably what the thing that I insist most to my young colleagues to get into that position, etc. So we go step by step. I think that it is true that one of the challenging aspects of teaching CTOs is that in some cases you cannot handle 100% of the case to the fellow. You have to be there and you have to take cover, because at the end of the day, it is the safety of the patient, and there are certain points, at a difference with other situations where the fellow can do the whole thing with you at your side. In these cases, probably sometimes you have to do this particular aspect. From a broader perspective, the problem I've seen in disseminating knowledge about CTO PCI comes from the personality of interventionists who have an alpha male type of personality, a type A personality. What happens in this situation is that you can be in a congress session, in a teaching session, where the people in the panel are trying to impress each other. So they are not speaking up front. They are not speaking to the people that are in the audience. They are just trying, to say to the peers that are sitting there what happens. And I don't know if you have sensed this, but hopefully, luckily, or things are improving. There are many good now platforms for education in CTOs. We could name many, but certainly there are many. But I think that is a problem that has been a sort of chronic problem. At the very beginning, when I was learning, there was an additional problem. That was the problem of the language. The people that had made a major breakthrough were the Japanese operators. And the Japanese operators, many of them will not master the English language. And second is that from the cultural way of teaching is different than the West. It is much more based on the fact that the sensei, the master, is doing a case, and the people that are learning are watching, and in a way getting embedded in this. But this is less relies less on, say, a structured description of what the operator is doing. So these are a few comments about education. My experience with my own fellows, but from a broader perspective, what I've seen over many years in dedicated courses, etc.
Yeah, no, absolutely agree with you. Sometimes it's hard to come. Even today, even with other countries, sometimes there is a language barrier which makes it a little harder, although I think we have made a lot of improvement on that. But to your point about the complications and adversity, which is unfortunately still something relatively common in the CTO world, what has been your approach when things don't go well and you have a failure or a complication? Do you get depressed? How do you recover from these cases?
First, of course, we try to lower the threshold, to change what we are doing whenever we see a major complication or something that may end up in being a major complication, and I think that this is one of the major challenges or objectives we should have today in CDOs, is that they should be as safe as any other intervention. It would be unacceptable that revascularization in chronic coronary syndromes is associated with relevant rates of death or myocardial infarction, etc. So I think that we really have to try to make this procedure safe. So therefore, I will say that whenever I'm very sensitive to see if that wire that is going through the collateral, suddenly is making a funny movement, which may indicate that it is causing a small hematoma or whatever, and therefore I'm not going to insist that much. If I start seeing this foreign, I will verify what happens, and then I will switch to a different perspective. To be honest, and this may sound strange, but it's perhaps because of this attitude of saying, listen, I do not want to embark into performing a case in whom I do not believe that the patient is going to have some sort of benefit. That's something that is important. In most cases, when I have a complication, that wasn't expected or that happens, then I do not get depressed. Of course, I'm the most clear with the family, with the patient, etc., about what happened. But what we try is to be very analytical about what happened, and of course, try to make that happen. But we know that may happen anyway. But the objective is, and that may be different from different operators. While we have to strive to achieve revascularization of an occluded vessel when we believe that is is good for the patient, I will be ready to change my approach quickly when I see something that is going detouring in the wrong way, or even to consider re-staging to perform a new intervention in the future.
And then when you do procedures, when they get challenging or stressful, do you get anxious? Do you get stressed out, or you're able to calm and direct them? How does it affect you psychologically, even if it's going well or there's no major complication? How do those procedures affect you at this point in time?
Yeah. Well, it is certainly a type of intervention where you really have to have mental skills, and you really have to develop them. And there are a number of. It's one of my favorite questions, to any CT operator is, how do you endure when you are 4 hours, in a procedure? Give us some hints on the tricks you have, So the first one is never work alone. So CTOs, I always embark with another colleague. Even if we have a fellow, it will be two interventional cardiologists plus a fellow, and so even the concept of first operator. I mean, sometimes we drop, and you continue whatever. But this, I think, is extremely important because it really keeps you in time. You have four eyes instead of two eyes, being able to identify this or whatever. And if something happens, then you handle the situation much better. This is one of the first things. The second thing is I try to take distance from what is happening. So at some point I may say, listen, I'm going to change my scrub. Uh, take over for a while. I go out, take my shower. I will not say that I take a shower, but I could take a shower if needed, but I refresh myself or whatever, and then I walk in. And before doing that, I also reassure myself like things like, okay, what is ACG? Give me ACG. 250. Okay, what is the pressure? Blah blah blah. So I take, in a way, positive reinforcement from knowing that the patient is doing well, and also making sure that I'm able to take distance. I think that this is something very important. Now, I started practicing yoga very early in my life, when I was 17. And it's I think that what I learned at that time, and that has been in a way accompanying from all my life, has helped me a lot in terms of this mental skill of being able to take distance, understand when your mind is taking the wrong direction, that you really need to stop, refresh, etc. I think that is something very helpful. And I will encourage, any complex PCI operator to get training in this type of ways to control stress, to get distance, in addition, of course, to proper planning, etc.
So essentially doing a little timeout during the case when things are getting tough or the situation is unclear, clear your mind and move on, which I think is a great suggestion. And I love your points about yoga. I was going to ask you what keeps you in good shape and be able to do these complex procedures and the other heavy load you have in terms of research and education as well. So how important has yoga been in that respect, and other things that you do to keep fit?
I try to do regular exercise. I do a lot of walking. By the way, I think that also that is something that is important. I mean, just walking. Sometimes I listen podcasts, but in many occasions I do not listen to any podcasts. I mean, just the walking and thinking. Remember Aristotle, that he was called a peripathetic because he was making reflections, walking with his pupils around the Acropolis in Athens. I mean, this idea of walking and changing your mindset by what comes with physical exercise, I think that is something that is very good, and I like it very much. In many occasions, I have had solutions to problems by doing that. But I try to keep a, so to speak, a healthy life as much as much as I can. But certainly, meditation is one of the big, so to speak, tools in understanding your mind, being able to bring it to a restful state, take distance. I think.
Wonderful. And then along the same lines, how many hours do you sleep every day?
Less than I should. That's the short thing. But no, typically I wake up at around 6:30. I'm in hospital at 8 o'clock. That is when we start. So I try to keep at least 6 hours a day. But as I say, it probably would be better to have a bit more sleep. And then, of course, during the weekends or now, for example, that I'm having the holiday break, the Christmas holiday break. I will try to sleep a bit more when it is
Wonderful.
possible.
And what are your favorite books or favorite movie?
Wow, that's very difficult. Yeah, what favorite book? Well, the favorite movies. I think that probably will be. I think that the film that I've seen more times in my lifetime is La Dolce Vita, which is a film by Fellini, Italian director, a fantastic film in the Roma in the 60s. But I like many others. I certainly, nobody has seen this film. I will recommend the Sky Over Berlin, or the Himmel über Berlin, by Being Benders. It's a fantastic movie also that really caused me a lot of impression. I like cinema. I like a lot of cinema. I see Japanese cinema, of course. I see Korean cinema. I see lots of cinema from many other countries in the world, and I think that it's a fantastic tool of learning stories. And regarding books, I read a lot. I tend to read a lot of essay. So and philosophy, and also time to time more fiction. What will be my favorite book? That's difficult to say. Yeah, well, that's difficult to say. But probably, if I have just to pick out one of my mind, and talking about things that we are discussing, there is a book from George Steiner, who was originally from Vienna but ended up living in Oxford. That is called 10 Reasons for the Sadness of Thought. I think that you can get it for free in internet. 10 Reasons for Sadness of Thought, and it's an amazing reflection about how the human mind works. I really recommend it to the colleagues that are looking to this, if they're interested to read something that is, a bit philosophical, but really very, very nice about how the mind works.
Wonderful. I guess we can all benefit from learning how the mind works. It's quite complicated. So Javier, how you've done so many things, both in the clinical arena, in the research education. What are you most proud of, both in your personal or professional life?
Well, I think obviously, the more senior you become, I think that you are the more proud of the things that have contributed to the development of others. I mean, that's very clear. That's certainly. So in that aspect, I think that, anything that I may have done to improve the life of my family and my the mentees and my team, etc., will be the most important thing. And that's probably the reason why, I pay so much importance to mentoring and to help, to pass the torch, of course, to the younger colleagues, etc. My friends are very important for me. So that's so they are the people that stimulate me, the people that I have learned from, the people that I am always amazed, of what they share. Even if I have heard the same story, 100 times, I always get amazed next time. So my friends are very important for me as well. And I think that that's obviously something that sustains me. I think it's really, really important to get that. In addition to that, any doctor has, a magical weapon or a magical resource, which is the relationship with the patient. I mean, that is fantastic. I mean, and whenever in your career, and this is a message to the younger guys and telling my fellows, whenever in your career, you're going through times of uncertainty or hard times or whatever, you can always take shelter in the relationship with your patients. That's at the core of our profession, and certainly it is the most rewarding, fulfilling aspect, and something that keeps you going. I think that's the core of it, and we're very, very, we're very fortunate for that. And the last thing is, of course, remember always how privileged you are as an interventional cardiologist to have access to in live. There's so many things taking place at the level of the heart, the level of life, etc. So there are fantastic opportunities always to get renewed, and it's the best possible. These things are the best possible protections against burnout, I believe. Remember your privileged position. Keep curiosity ongoing, because that's what will keep you going on.
Wonderful. And then, what are you most excited about right now in terms of clinical work or research or education? What are the things that you're most excited about the present and the future?
In terms of where to focus my work, I think that my main focus is improving the quality of PCI. I think that the quality of PCI at a global scale is suboptimal. Because still, PCI is still practiced basically, with the introduction of different tools, etc., but basically in the same way that was performed at the time of Andreas Grunsick. I mean, you are using angiography to identify the lesions that are to be treated, plan your procedure, decide where you're going to plant your stent, check if your stent is good, whatever, etc. And with the type of patients that the patients that we are treating nowadays are not the patients that Andreas was treating. The patients are much more challenging. They are much more complex, And for these patients, you have to find if you are going to do it, you're going to do PCI. You have to do it well. I'm keeping aside acute coronary syndromes. Even for acute coronary syndromes, it will be the same. We will speak later because we now understand that complete revascularization in patients with acute coronary syndromes is extremely important. This is something that we know. And if you are going to embark in complete revascularization, again, you really move to a different level of complexity where you really need to do a good job. But in chronic coronary syndromes, the benefits of revascularization is very slim compared with medical therapy. So if you really are going to do a job, you really have to do it well. Because there is a huge disconnect between what happens with your perception of what you have achieved and what may happen to the patient. And you always see this case, that somebody has nailed the ostium, and probably they place the stent in the LAD to the ostium, but the patient comes 3 years later, and you can see that the stent is grossly protruding into the left main and now has some thrombosis over there. The colleague who has performed the procedure doesn't know anything about what happened to the patient. But of course, it had consequences. The fact that the procedure was suboptimal had consequences for the patient. So I think that to me, Manos, this is my at this point is my main, so to speak, area of work, trying to send a message out of saying, listen, I know that you're under a lot of pressure. I know that you have backlist every day. I know that your institution is saying, keep doing it the same thing, whether you want to change it. But we really have to drive the change. We really have to drive the change because we really have to understand, and it's something that a personal experience cannot really grasp that. You need data. We know that suboptimal PCI has consequences. And the more complex the case, the higher the consequences. So I think that's, is the area that I'm more interested in now, Manus.
And this is with physiology, imaging, understanding better what we're doing, checking the result. Is that the main way so we can actually improve the quality of PCI these days?
Anything that is at your hand, CT angiography, it's an amazing tool. There is this interventional schizophrenia by which the operator is doing a TAVI and then spends 30 minutes looking to the CT, making accurate measurements of the aortic annulus and the distance of the coronary arteries, to the Valsalva sinus, blah, 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 blah. And then moves to the cath lab, and then say, I think that's about 3.5. Yeah, no, but give me a 3 and I'm going to put it out. This type of things, this is not tenable. This is not tenable. I don't think that this is something that we should not understand. And actually, there are many things that CT operators can contribute to the so to speak, wider interventional audience in terms of improving the procedures, because we have to address many aspects. I'll give you an example. I'm now, for example, very much committed to to teach or to, and also to build together a structured pathway to ultra-low contrast PCI. And that the difference from the American school, perhaps, which that has made a strong emphasis in patients with chronic renal failure, with chronic kidney disease, sorry, I realized that I learned ultra-low contrast PCI with the Japanese operators doing CTOs, because in a 4-hour procedure, or 5-hour procedure, these operators were making 3 injections of contrast. And it makes a lot of sense, because any CT operator knows that if you are liberal with the use of contrast, you will not be able to do the job. You will have to stop before time, before that, and that is before because you have achieved the maximal, say, reasonable dose of contrast that you can give. And it's a good example that ultra-low contrast PCI, for example, is an important tool if you want to have a good quality result, or if you want to address complex PCI, irrespective of the renal function, for example. So CT operators, the operators that are performing chip procedure, have a lot of things to teach or to share with the wider interventional cardiology audience in terms of how to improve the quality of PCI, I believe.
Wonderful. So, if you had to give some final pieces of advice to the people who are starting now their journey, their fellows or early career people who want to do PCI, complex PCI, would get involved in research, what are the things that you would advise them to do to be successful down the line?
Well, probably I will recommend them first to achieve a good, say, basis of clinical work, along, also, of course, with the possibility of developing curiosity about what they do. I mean, again, as I told you, curiosity is the biggest protection against burnout. And a good way to do that is to perform research. So research has also the additional advantage in terms of, in addition to improving knowledge or advancing in knowledge, it has the additional advantage of generating an inquisitive spirit, a critical spirit about how data is obtained, etc., etc. Once that they have achieved this particular goal, or along that, I would recommend them also to get involved in education. Why education? Because it is really, really important to learn how to communicate properly, to learn how to share. There are multiple beneficiaries of this. One of them is the patient. I mean, you really have to be able to communicate well with the patient. That's something that will come naturally if you are able to communicate with other people. When you are performing education, sometimes you have to revisit the way that you are thinking, because you will identify that actually you are not, you have voids in your own knowledge, and that you have to revisit them. So it's a good way also of checking if you are really mastering what you are sharing or teaching to other people. And probably I will, there's a final aspect that will be the societary aspect, or more political aspect, involving with scientific organizations. What I've seen is that the people that get more out of it are those that have covered already the first 3 steps that I am mentioning, that they have already some, competence as interventionalists. They have already obtained a track record in research, and that they're interested in education. And that's, of course, the societary involvement is very important, because it will help you also to change things at the wider, at larger scale, which is something that is really, really important. Not everybody will be interested in this, but my recommendation will be to find the right time for it, because if you do it at the very beginning, probably may interfere with the other steps that I have mentioned. But there are so many ways that this is not chiseled in marble. There are so many ways of making your way. That this is a wild proposal, just.
Yeah, absolutely. And I think following your example too, I think training in different institutions and seeing different ways of practice that also can play a huge role in shaping you and opening up your mind, both for the clinical part, as you say, but also for the research and help forge these relationships for life that can help you move on down the line. So again, thank you so much, Javier. That was amazing. Truly excited and inspired to listen from you. Very excited to work with you and look forward to further working together. Thank you so much.
Well, thank you very much, Manos. A great pleasure.
Thank you for listening to the Sensei podcast.